Good morning, everyone. First and foremost, I would like to thank Gulf Interventional Society giving me this opportunity present in such a prestigious platform. So I will be discussing a case of balloon rupture and retaining balloon material in left main coronary artery. How we manage in a resource limited setting. So this is a 60-year-old male, anterior-STEMI. Thrombolysis was done. Then around middle of the night, we got a call patient having ongoing chest pain still. So we got down the patient to the cath lab. So this is the angiogram results where we can appreciate there is a, in the spider view, we can appreciate there is a tubular plaque disease which may be unstable plaque which causing the symptoms. So right coronary system was normal. So we decided to go for a stent, which is the available stent. Status is 22. We stented. During the post dilatation is the last balloon dilatation, where we can appreciate there is a balloon rupture just proximal to the balloon where it attached to the shaft. Yes. Yeah. So we were a little panicked, but we tried to pull it out the balloon. While trying to pull it out, take it out, the balloon is stripped off and got stuck in the left main. So after that, before that, we thought of whether it is a clot or definitely there's a balloon material associated, clot or associated with the dissection with the clot formation. So what we did was we wired the circumflex, then we inserted the aspiration catheter, and first we gave the initial intracoronary abscissiment. So we tried that. That time we tried a little bit aspiration as well, but the angiogram results was same. So with that time we didn't have any snares. We only had the biopsy guide, and it won't reach up to even it didn't cross the guideline. So what we did was we just took the two balloon, 2 millimeter 2 into 8 millimeter balloon, and inflated to 8 atm. We tried to push the balloon, pull the balloon towards the guide catheter. Our purpose was struck the balloon between the guide catheter and the inflated balloon, but unfortunately we couldn't got it. We did from the circumflex as well as the LAD. The results was same. Then what we did, we tried to crush the balloon, same balloon. We went up to 8 atm. We went up to 8 atm, but results was same. As the patient is throughout the hemodynamically stable and staff also exhausted, we didn't have any snares at the moment, so we stopped the procedure. So we managed with the, fortunately, there is no complication up to next 48 hours. We initially give the abscissiment infusion, then enoxaparin, AC inhibitors, dual antiplatelet therapy. So after 48 hours, routine cath lab, we took the patient to the cath lab, where we wired the LADs, no problem. But wiring the circumflex was very difficult. It took more than half an hour. So put the IVAS run it's a manual pullback, so I have cropped the images as well. IVAS run through the LAD to LMCA, where we can appreciate there is a balloon material without any dissection or clot formation in the 6 to 7 o'clock position. So we again tried this our unconventional technique, maybe the guerrilla technique. We put the two balloon in the simultaneously in the LAD and LCX. We tried to pull it out. We fortunately or unfortunately balloon was remain there. So that was the third picture shows that we tried twice. We didn't do further. So what we did was we had a two option, surgical option as well as the stenting. we didn't have snares, so we chose that putting a stent across the circumflex to left main. So what we did the pot and then recrossing and kissing and final pot. So this was a final results. The final IVUS shows that apose stent with balloon material crust between the left main and stent. So what the lesson learned is definitely thrombus and definitely balloon material and thrombus or dissection. So IVUS has confirmed that they're only the balloon material. So there are so many techniques, snares we didn't have. So we could have used the multiple wire techniques and unconventional balloon technique. We didn't try with the homemade snares. The first operator don't want to put the homemade snares in the coronary system. And we really underestimated the balloon material embolization risk. So there are other options, surgical and DSE. We choose that drug-eluted stents. After stenting, we initially thought of the infection. We thought of initially giving the prophylaxis to this patient, but we didn't give, but fortunately patient didn't get any infection. And thrombosis risks, what we managed with initially triple therapy for the 2 weeks with the rivaroxaban 5 milligram. And and we followed up the patient up to 6 months, and still patient doing well. After 6 months, we did the exercise treadmill test. It was negative. He did the stage 3 and target heart rate was achieved. Still was patient asymptomatic. Then how should it prevent? So that balloon selection and should not go beyond the rated burst pressure. And usually we do the morbidity mortality meeting, and so learning from others' misfortunes. Thank you.